I would like to guide you a little bit through why we have chosen this afternoon to talk about digital health technologies and to show you some updates on published data. So, and by the way, I think this week is a perfect week to talk about digital health because on one hand, last Sunday, it was the World Health Day, and there has been a lot of statements going around from different countries saying that it's really important and it's time to implement faster everything on digital health and telemedicine and telemonitoring. So I think we are on the right spot here in Marseille. And on the other hand, another information that came across was that for the first time, the population above 65 years old are exceeding the global population under 5 years old. So, and in looking at that, it's pretty clear that the implications of that could be massive on our healthcare systems. If we have a look on the life expectancy, and it's a picture of 2015, we see that it is already pretty high, and it was already pretty high in 2015, and this also shows that there will be a high burden on all our healthcare systems around the world. And on one hand, there is more money spent on health generally, which then again leads to a longer or a higher life expectancy, which then again belongs is going to use more healthcare systems because people are getting older and getting sicker and needing more healthcare systems. So coming through the sleep disorder breathing topic and the digital health technologies, and looking at the presentations made last year on the global OSA prevalence that you have all seen certainly, and looking at the numbers, and if we just take the numbers on the AHI above 15, that we have more than 424 million of people that are waiting to get screened or diagnosed for obstructive sleep apnea, it goes in the same line with what I said before in terms of the high burden on the healthcare systems. So there are some challenges that we will face and we are already facing in different countries. One of them being, as I said, the need of having those people screened and diagnosed and then treated, obviously, which requires more resources, either in hospitals or at the home care provider sites, and not to forget all those people that are already treated and that need some follow-up to make sure that they stay on treatment, that they stay compliant and adherent long-term. With all of that, looking at the limitation by the different budget constraints, it is quite challenging. It will need more efficient treatment processes in future. And with all of that, not to forget then the primary objective is definitely to make sure that the patient receives the quality care that he needs. So the question coming with all these challenges is, do we have at least one kind of answer or some parts of answer that we could provide? And well, the good news is that ResMed is driving since a couple of years already the implementation of patient management systems like AirView. And if you look at the numbers of patients that are already in AirView, this shows that we are looking into some ways of, on one hand, reducing costs and trying to find some efficient ways of treating those patients, and on the other hand, not to forget to make sure that the patients receive the care that they need. And one thing that I would like to raise is the fact that we should not underestimate, and that has been just raised in the presentation just before, that the patient engagement will or have to and will increase far more. And again, here I think ResMed has been active in helping and supporting ways of getting more patient engagement. And we have already been publishing different, there are some publications already out there. On one hand, on AirView, as I said, a patient management system that the ultimate goal is to reduce the labor costs, which could be shown here, which ends up in the reduction of costs at nearly 60%, giving free capacities and to include more patients into the funnel and get more patients treated. On the other hand, as I said, the patient engagement tools like MyAir, which are extremely important to make sure that patients keep adherent to their patient on the long term. And it also shows that there is more and more, or the systems ask more and more the patients to be more responsible for their own health. And I will show you a couple of publications that have been done in the last couple of years, one being from Atul Malhotra and his group on patient engagement, showing that through these patient engagement tools, there is at least 1 hour increased usage per night. And this has been published last year. Another one that came from the PwC group already in 2016, showing that empowering the sleep apnea patient will lead to an increased adherence. And last but not least, the group of Holger Wörle showed that the proactive patient management leads to a lowered therapy termination overall. So let me conclude this short introduction with saying that today's generation, they grow up with using all these kind of technologies. So for them, it's quite normal to search for digital solutions when they face medical issues. And I would agree that if we are not able to properly and safely integrate digital health into healthcare today, there will be some major issues coming through. And another statement that I found quite interesting and well said from a director of a healthcare research organization, saying that big data, data science, and artificial intelligence will only deliver value if innovations can be translated to patient care and clinical workflow. And this will mean that the effective use of big data will be the key in all of that. And with that, I would like to give the word to Professor Jean-Louis Pépin. Thank you very much.
We are going to move on to the use of big data to generate clinical intelligence, which is quite different than artificial intelligence, and the application of this regarding positive airway pressure therapies. This is a very recent review in hepatology and gastroenterology, but in the different topics, we have exactly the same situation. We have a big data storm, a big data avalanche, and we have to manage and we have to have some information going on. You have medical records, imaging, omics data and biomarkers, e-health application, very importantly, administrative database to look at the health resources, clinical trial data, social media. We have big data platform for data integration, transformation, analysis. And at the end, we can get information regarding phenotyping or phenomapping. We can implement predictive risk models. And the final goal, as you said, is improve the public health, improve resource allocation with the increase in the mean age, and implement precision medicine. This is an example of the impact of social medias. You can see that this is a German researcher. He is working on the picture at the restaurant, and he is able to demonstrate the mean BMI in the different states in the US only by looking at the picture in Instagram. This is another incredible study. A classical cohort in the US with a long-term follow-up at 10 years, showing the predictors for mortality and late cardiovascular events. As expected, when you are obese, hypertensive, with diabetes, you are at increased risk. But when you look only to tweets, and you have some tweets related to depression, chronic disease, irritability, you can read the different tweets. This is highly predictive of your mortality and cardiovascular events. looking at the different tweets, we can expect that the life expectancy of the President of the United States is not good, you know. Going back to sleep apnea and the specific context of sleep apnea, we have different symptoms that can modulate patients' engagement, and we have a lot of cardiovascular and metabolic comorbidities. And what is really specific in the field of sleep apnea is that we have a lot of telemonitoring data already available. It was one of your slides. Just remember, 9 million people using telemonitoring of CPAP device, more than 1.5 million using a smartphone application. This is a unique experience in the different chronic device. And probably you know, oral appliance probably, and Marie will comment on that, will be able to transmit some information. This is also the case for positional therapy, so we are going to move to a really connected world. I would like to demonstrate how this data coming from telemonitoring make available some information regarding, for example, central sleep apnea. As you know, we have mainly obstructive sleep apnea, characterized by collapses of the upper airway, but we have also some people with unstable respiratory control and some shift from obstructive to central apnea. If you look at a typical OSA subject, when you treat with CPAP, you have some patient exhibiting treatment-emergent central sleep apnea. You have also at diagnosis some people with coexisting CSA and OSA. Some have persistent central sleep apnea, and some have on CPAP a reduction in the central component. Just a clinical example, you can see these people, you have a transcutaneous PCO2, hypnogram, oximetry. At the beginning of the night, you have typical obstructive hypopneas. At the end of the night, you have typical central apneas, long-lasting central apneas. This is a coexisting central sleep apnea. And when you look at the study, the prevalence is unknown. You have a huge variability between one study to another. In some studies, you have a 5% prevalence of emergent central sleep apnea. In other studies, mainly split night studies, you have a prevalence up to 20%. This is another way to present the different studies. As you can see, in the largest studies, the prevalence is close to 5. In study with small sample size, the prevalence is close to 20%. So looking at the question, we need to determine the prevalence of emergent, persistent, transient central sleep apnea to have large, unbiased population in real-life data. And we have to look at not only one night, but the evolution of these parameters across a significant number of nights to establish the trajectories of central sleep apnea under CPAP. And it is what we did with the support of ResMed and with an independent consortium of academic experts. You can see the guys working on this data, Atul Malhotra from San Diego, Peter Sistuli, Peter is attending the meeting, Olga Vori, and myself. And what we did is to look at a significant number of patients initiated on CPAP. This is the details of the flow chart. At the end, we were able to look at more than 133,000 people beginning CPAP. And what you can see in this significant number, you have typical OSA. This is day 1, night 90, no central event. You have 4 different phenotypes, one transient phenotype with a decrease on CPAP, one emergent phenotype, and one persistent central sleep apnea phenotype. And using this highly significant number of patients and big data, you can say that the prevalence, the global prevalence of central sleep apnea under CPAP is no more than 3.7%. and transient or emergent is close to 1%. So using big data, we have very strong information regarding the prevalence of the different phenotypes of central sleep apnea. And what is interesting is that all these types of transient, persistent, or emergent central sleep apnea are linked to the outcome, which is really, really important. It's not only big data analysis, it's also related to the patient's outcome. And all these situations are linked to a higher risk of therapy termination in these different subgroups. The second question is, should we move to another treatment in this situation? So you have patients with persistent emergent central sleep apnea on CPAP with more than 5 events per hour. Should we change the treatment? Again, looking to a big data analysis, we did demonstrate that when you shift from CPAP to ASV, you have a significant improvement. This paper has been recently published in Journal of Clinical Sleep Medicine. As you can see, in people with persistent central events, there is a progressive decrease in CPAP adherence. You have persistent events, and when you move to ASV, immediately you have an increase in adherence, and the adherence is very stable, and as expected, you have a reduction in the number of residual events. So using big data, this is a demonstration, I think a convincing demonstration. When you have persistent or emergent central sleep apnea, you have a higher risk of therapy termination. And when you shift to adapted servoventilation, you have an improvement in adherence. The question at this point is what is the clinical phenotype behind emergent central sleep apnea and persistent sleep apnea? Using the data generated by the CPAP, we only have limited information, gender and age. So what we did was to look at in our large database in France to have the explaining factors for residual central events under CPAP. And the paper is in revision in respirology. We look at 12,000 people with a residual AHI more than 5 at follow-up. This is a multivariate analysis, and you can see that the significant factors associated with persistent central or obstructive event under CPAP were age, were all the cardiovascular disease, were sedentarity, and also for obstructive events, facial mask. So you have explanation for central events, cardiovascular morbidity, age, sedentarity, and when you have a facial mask, you have an increased risk of obstructive events under CPAP. So if you have this kind of patient with associated cardiovascular morbidity, you have to look at very cautiously to the telemonitoring, because in this population, you can expect a higher risk of central events. So if we summarize, repeated measure based on real-life monitoring data allows to better understand what is occurring in CPAP. You can use large population-based sample of CPAP device. You can see that treatment-emergent CSA is associated with a higher risk for therapy termination. When you have a lower compliance due to resident or treatment-emergent CSA, it's probably good to switch to ASV therapy, and there is behind a specific phenotype, low physical activity, age, and cardiovascular disease. Now, as other example, in clinical practice, what is the interest of telemonitoring of CPAP devices? And I will show you some clinical examples. It's not big data, but learning from big data, we can understand some individual situation. With Jean-Christian Borel, we have worked a lot on the impact of the different types of interface. And this is a very nice case report published by the Brazilian group. You can see this patient during a night titration low level of CPAP pressure with a nasal mask. Moving to a facial mask, you have an increased need in pressures. There is a recent meta-analysis published by the same group showing when you are using a raw nasal mask, you have a higher residual RHI because you have some people, the mask is pushing backwards the mandible. And this is a typical example in clinical practice. This is the time of my clinical visit. And you can see the telemonitoring between March 2018 to March 2019. Nasal mask. The mask was changed to a facial mask, and you can see the impact of the change in the interface. This is the example of a patient with a progressive increase in central events on telemonitoring. There is a myocardial infarction here, and when you look to the raw data, you can see chain structure respiration. This is a very recent example. I did receive a letter from the local network for cardiac failure saying this patient has been hospitalized for cardiac failure. I go back to the telemonitoring, and you can see the huge increase and the decrease in adherence related to a deterioration in cardiac function. So using artificial intelligence, probably in the next year, we will be able to anticipate cardiac failure, acute cardiac failure in this patient treated by CPAP therapy. Another example, I saw this patient during my clinics and I said, why you are not using CPAP during these periods? And actually, the patient was using both CPAP and neural appliance, and this is a period of traveling. And this is a nice demonstration of the combination between the two situations. And I am fairly convinced that a combination of oral appliances and CPAP in young people with a lot of travels is really interesting. And going back to your presentation, also Daniela, again, we need not only the telemonitoring, big data analysis, but also to implement some artificial intelligence for improving the understanding and also for proposing some alerts to the home care providers and to the physician. And there is a specific issue in Nature Medicine at the beginning of the year regarding the different aspects of deep learning and artificial intelligence in medicine. We are accumulating big data. This is going to be a way to deep learning for the healthcare system, for improving clinical decision with, at the end, a synthesis for recommendation. For example, there is an alert in telemonitoring suggesting cardiac failure, and this is going to completely reshape the health system. The last part of the talk is related to the combination of different big data information. I will be back to the patient engagement tools. So this is my hair. You have in the mornings the opportunity to look at your leaks, your CPAP adherence, your residual events, to see some videos related to how to adapt your mask. And this is a paper from Atul Malhotra in chest last year, showing when you are using my hair, additionally to the telemonitoring, you have an increase in adherence. And you can see the proportion of the patient with very high adherence is improved by the use of the patient engagement tool. And this is another interesting application of big data. We have we have telemonitoring of the CPAP device, but many of these patients also have chronic disease. And now we have telemonitoring for glucose levels. And this is the example of telemonitoring from the pacemakers. Now all the brands of pacemakers are able to identify apnea, and we have validated this and published different studies with Livanova, Boston Scientific, etc. And you have every night an information regarding the respiratory disturbance index, and you have also a correlation with the arrhythmic events from the pacemakers. And you have the example of this patient. This is the threshold for sleep apnea. You can see that every night the RDI was above the threshold. The cardiologist was addressing the patient to the sleep lab. He was on CPAP here, and you can see the evolution of HI, not with the CPAP device, but with the telemonitoring from the pacemaker. And the next step is to combine these different opportunities for big data and telemonitoring. And was interesting for the patient. You can see the number of atrioventricular blocks in the 3 months before CPAP was hugely reduced in the 6 months under CPAP, showing to the patient and to the physician that the treatment of sleep apnea has an impact on arrhythmias. And that's why now this is the very recent recommendation of the American Academy of Sleep Medicine regarding OSA treatment with PAP therapies. And you can see that there is a specific recommendation for telemonitoring in the management of these patients. And the next step for me, so we have discussed phenomaping with the different categories of central sleep apnea. We have discussed the needs for predictive risk models for cardiac failure, for example, the capability of reducing the number of visits at home. And now the next step is to combine this big data and telemonitoring from the CPAP device with the information from the administrative database. And we have different projects both in France and in the US to look at whether when you increase the adherence with CPAP, you are going to reduce the healthcare costs, the hospitalizations, etc. And this is quite complicated, but this is a very recent paper regarding COPD in ERG Open, suggesting that you can also use the social network to identify patient symptoms, to increase diagnosis, to assess the effects of treatment, and to improve the management. So in the next year, we will have a combination of data generated by the patient via the smartphones, some connected device, some data generated by the CPAP device, but also some communities and some activities on social networks. So thank you very much for your attention. But perhaps we can take some questions now, if you agree.
We all need now to know more about computer science, about machine learning and so on. It's impressive how well all the devices that we own can give a lot of information in some huge cloud and database, and you can look at them and use them for medical care. My question is, if the patient doesn't have a smartphone or a smart device like tablets or so on, do those patients receive feedbacks regarding some events, some related to compliance or CPAP? Okay, because if they have smartphones, always they can be informed, you didn't use enough, you have some probably cardiovascular situation, you should do something about it. But patients without smart devices can be involved in this impressive, fantastic future work?
I think it depends on the different national healthcare organizations. For example, in France, the home care providers are doing that. They can call the patient or go at home or organize some visits at home. In other countries, it's completely impossible.
Or automatic text message, maybe?
Yeah, automatic. There is an incredible study from Dennis Wang. You did present this, Daniela, and he demonstrated that just sending some text messaging, not for an alert, just to coach the patient, was increasing the adherence by 1 hour. But as discussed in the previous session, we need a combination of face-to-face visits with all these tools. And I think, again, that social networks are going to be really important to understand more what is the patient ecosystem, the symptoms, the socioeconomic situation, etc. Yes, ma'am.
Are you working with telemonitoring for all the appliances? Do you see something in the? Do you see something in the future to achieve that?
I know that there are some projects ongoing. I think it's confidential for the moment, but it's probably not so difficult to have some telemonitoring for our appliances, and it's really important, yeah.
We had mostly adherence, so I don't know. Maybe it can be developed further. It's really exciting what you present.
Sure. And to assess titration, etc. Okay. So thank you very much.